Atrial flutter, an electrophysiologic overview. Welcome to Atrial flutter, an electrophysiologic overview. This module contains a discussion of the various characteristics of atrial flutter. ECG recognition and treatment of atrial flutter will also be explored. Focus is given to the use of radiofrequency, RF, ablation as a treatment for atrial flutter. Module 2, M.D. Department of Pacemaker and Electrophysiology. Raja A Cardiovascular Medical and Research Center, RCMRC. Objectives: atrial flutter. Identify mechanisms and characteristics of atrial flutter. Recognize ECG and intracardiac electrograms depicting different types of atrial flutter. Discuss treatment options for atrial flutter. Outline: atrial flutter. Description. 2. Characteristics. Definition. Types and features. Mechanism. Circuit recognition. ECG and intracardiac recognition. This module will start by discussing the characteristics and ECG findings of atrial flutter. Outline: atrial flutter. Pacing techniques. Entrainment. Treatment options. RF ablation. Future directions. The module will then discuss treatment options of atrial flutter, with an emphasis on RF ablation. Atrial flutter, rapid and regular form of atrial tachycardia. Usually paroxysmal. More common in men than women, MF, 4.7 to 1. Sustained by macro reentrance circuit. In most cases, circuit is confined to the right atrium and left atrium is passive bystander. In some types of atrial flutter, arrhythmia circuit located in left atrium. Episodes can last from seconds to years. Chronic atrial flutter usually progresses to atrial fibrillation. Atrial flutter is a rapid and regular form of reentrant atrial tachycardia. It is usually paroxysmal, and it is sustained by a macro reentry circuit located in the right atrial myocardium. Flutter episodes can last from seconds to years. Patients presenting with paroxysms of atrial flutter often have normal hearts, whereas patients with chronic atrial flutter usually have underlying heart disease. Chronic atrial flutter eventually converts to chronic atrial fibrillation. Atrial flutter. A unique population in which atrial flutter occurs commonly is in patients in the first week after open heart surgery, a third of postoperative SVTs. It is also seen in association with chronic obstructive pulmonary disease, mitral or tricuspid valve disease, thyrotoxicosis, repair of congenital cardiac lesions in which the atria, most often the right atrium, is considerably incised, such as with the mustard, Senning, or Fontan procedure, or those with enlargement of the atria, especially right atrium. Reentry circuit of common atrial flutter. Anatomic barriers within the right atrium sustain the macro reentry circuit. The avenue node plays no part in the flutter circuit, so drugs aimed at altering the conduction of the avenue node have no effect on the atrial rate. Murati F. and Engeled J. of Med. 1999 340 to 534 to 544. Types and features. Flutter type mechanism: atrial rate cure. Typical counterclockwise 240 to 340 RFA. Macro reentry. Reverse typical clockwise 240 to 340 RFA. Atypical macro reentry 340 to 433 RFA. 90% of atrial flutters fall into the typical or reverse typical category. Mechanisms of flutter. Typical, counterclockwise and clockwise. A rapid and regular form of atrial tachycardia that is sustained by a macro reentrant circuit which utilizes a tricuspid isthmus. Atypical. Atrial reentry is independent from tricuspid isthmus. Mostly, reentry occur around scar tissue after surgery. In some cases, reentry occur around left atrium. Depending on the type of atrial flutter, the mechanism will vary. A discussion of each type of flutter follows, along with ECG and intracardiac recording examples. A macro-reentrance circuit can be defined as an arrhythmia pathway in which the electrical impulse travels through a relatively large region of tissue. Arrhythmias caused by macro-reentrance circuits often can be cured by ablation of a critical portion of the circuit. Atypical atrial flutter does not use the critical isthmus as used in type I flutter. Macro-reentrant atrial tachycardia occurs frequently after surgery for congenital heart disease. Typical flutter mechanism: induction, termination. Counterclockwise macro-reentrance circuit that utilizes a cavatricuspid isthmus to sustain circuit. Induction: fast atrial pacing and/or the introduction of multiple premature beats near the low septum. Termination: rapid atrial pacing faster than the flutter rate. Cardioversion: spontaneous. Pharmacologic therapy. With counterclockwise flutter, a macro-reentrance circuit exists. This circuit is sustained by a critical isthmus. Induction of counterclockwise flutter can be accomplished with rapid atrial pacing under the introduction of multiple premature beats near the low septum. Termination of counterclockwise flutter may be accomplished with rapid atrial pacing, cardioversion, or with the use of medications, such as IA, IC, or class 3 antiarrhythmic drugs. The arrhythmia may also convert spontaneously. Isthmus conduction typical flutter. The mechanism of counterclockwise flutter is further illustrated on this slide. A counterclockwise flutter circuit can travel between A, the IVC, inferior vena cava, and CS, coronary sinus, os, or B, between the tricuspid annulus and the CS os. The key is that the isthmus is a critical portion of the circuit and the target for ablation. Typical flutter. Conover, Electrocardiography. 4th ed. Mosby 1998, 75, ECG recognition typical atrial flutter. Undulating atrial activity without a baseline. Atrial rate, 240 to 340 bpm. Rhythm, regular. Ventricular rate, variable. Dependent upon avenue node conduction properties. Usually a 2:1, 4:1 fixed conduction ratio. Recognition, sawtooth appearance on the surface ECG, negative deflections in inferior leads and positive deflection in V1. Atrial flutter is distinguished from atrial tachycardia by the faster rate. 1:1 avenue conduction ratio in atrial flutter may be seen in Wolff-Parkinson-White syndrome, most common, Longan-Levine syndrome, exercise, catecholamine therapy, phenytoin therapy, class I antiarrhythmic drug therapy, ACG recognition. Notice the sawtooth pattern of the flutter waves in this rhythm strip. This is typical of counterclockwise atrial flutter. The atrial rate can be 240 to 340 bpm. The ventricular response is fast, but it is regular. Other methods of A-flutter recognition. If diagnosis of atrial flutter is not clear from a standard ECG, any of a number of maneuvers can be useful. Vagal maneuvers, CSM, Valsalva maneuver. EGM recording by esophageal, transvenous, or epicardial electrodes. Pharmacologic agent, adenosine, esmolol, verapamil, diltiazem, or erifonium. In the presence of wild QRS tachycardia, drug intervention to establish the diagnosis of atrial flutter is dangerous and contraindicated. DC cardioversion is indicated. Atrial flutter is distinguished from atrial tachycardia by the faster rate. Intracardiac recording typical flutter. This slide contains an intracardiac recording of counterclockwise flutter. In counterclockwise flutter, the Christer catheter is draped around the lateral RA with the proximal catheter superior and the distal catheter inferior. As you can see from the activation sequence, the high crista is activated first, then the low crista, then the CS proximal, and then the his. Texas cardiac arrhythmia, PA. Intracardiac recording counterclockwise flutter. Zeitz, catheter ablation of arrhythmias, Futuro Publishing. Reverse typical flutter. Mechanism. clockwise macro reentrance circuit that utilizes a curvature cuspidismus to sustain circuit. Induction. Fast atrial pacing and/or the introduction of multiple premature beats. Termination. Rapid atrial pacing faster than the flutter rate. Cardioversion. Spontaneous. Pharmacologic therapy. As the name implies, with this flutter the macro reentrance circuit is clockwise. Pacing techniques for induction and termination of this arrhythmia are similar to those used in counterclockwise flutter. Treatment is similar to that discussed with counterclockwise flutter. ECG recognition. Clockwise atrial flutter. Annulating atrial activity without a baseline. Atrial rate, 240 to 340 bpm. Atrial rhythm, regular. Ventricular rate, variable. Dependent upon avenue node conduction properties. Usually a 2:1, 4:1 fixed conduction ratio. Recognition, notched upright pattern on the inferior surface ECG, positive deflections in inferior leads and negative deflection in V1. ACG characteristics of clockwise flutter are similar to those discussed in identifying counterclockwise flutter. A distinguishing difference is the pattern of the flutter waves. A notched upright pattern is often seen on the surface ECG inferior leads. ECG recognition. Texas cardiac arrhythmia, PA. This slide shows a 12-lead ECG depicting clockwise flutter. Texas cardiac arrhythmia, PA. ACG comparison. Counterclockwise, clockwise. Note that the inferior leads, 2, 3 and AVF, of counterclockwise flutters have a characteristic initial, broad sawtooth negative deflection followed by a less pronounced positive wave. In contrast, clockwise flutter has predominantly upgoing flutter waves in the inferior leads that are typically notched and in with a slightly negative component. Counterclockwise. Clockwise. Zipes, catheter ablation of arrhythmias, Futuro Publishing. Intracardiac recording reverse typical flutter. This slide is an intracardiac recording of clockwise flutter. The crystal catheter is positioned the same as noted in the counterclockwise recording of atrial flutter. Notice that the activation sequence is reversed from before. The low crista is activated before the high crista, then is A, and then the CS. Texas cardiac arrhythmia, PA. Intracardiac recording reverse typical flutter. Zipes, catheter ablation of arrhythmias, Futuro Publishing. Atypical flutter mechanism, induction, termination. Macro reentry that does not utilize curvature cuspidismus. Macro reentry occur mostly around surgical incision. Rare cases depends on functional barrier. Induction. Atrial pacing at faster rates than the flutter rate. Termination. Difficult with programmed pacing. Cardioversion. Pharmacologic therapy. In atypical flutter the reentry circuit may be confined to anatomic barriers including atrial tissue around the fossa ovalis, Bachmann's bundle, and the coronary sinus ostium. The true circuit for this type of flutter is unknown. Rapid, atypical atrial flutter may be a transitional rhythm between typical flutter and atrial fibrillation. Programmed pacing can convert the rhythm to atrial fibrillation. Ablation of true atypical flutter is not generally achievable at this time due to the unknown nature of the circuit. Pharmacologic therapy may consist of any drug that influences conduction velocity in the refractory period. The specific drugs are the same as with AFL. ECG recognition. Atypical atrial flutter. Annulating atrial activity without a baseline. Atrial rate, 340 to 433 bpm. Atrial rhythm, variable, flutter fib. Ventricular rate, variable. Dependent upon avenue node conduction properties. Recognition. Very fast rate and variable cycle length on surface ECG, may progress to atrial fibrillation. A difference in atypical flutter, when compared to counterclockwise and clockwise flutter, is the atrial rate and rhythm. In addition, This rhythm may progress to atrial fibrillation. Of note, some sources do not class this as flutter. Instead, it may be referred to as atrial tachycardia from a atriotomy scar, etc. Incisional atrial flutter. Atrial rate sometimes varies. Mechanism: incisional macro reentry. Complication of surgery: congenital heart disease. Treatment: ablated with good success using focused activation mapping to transect the isthmus of conductive tissue. The location of critical isthmus of conduction can vary depending on the location of the scarring. A thorough knowledge of the patient's history of heart surgery is needed. This arrhythmia may be seen with big atriotomy scars like ASD repairs or with CABG surgery, where the RA is incised to go on bypass. Evaluation of atrial flutter. Confirmation of flutter circuit. Confirm direction of rotation. During the EP study, the direction of the flutter circuit should be confirmed. Flutter should be present before the patient enters the lab. If not, attempts should be made to induce a tachycardia. Direction can be confirmed by using a multipole catheter positioned around the tricuspid annulus, and pacing near the isthmus. The direction of flutter is not as important as establishing isthmus dependence. Frankly, counterclockwise and clockwise are ablated the same. For some unknown reason, in clockwise flutter isthmus block is harder to obtain. Atypical flutter mimicking typical flutter. Activation sequence of typical atrial flutter, Lau view. Fluoroscopic PA and Lau views of a multipolar reference catheter. Concealed entrainment. Used to verify that isthmus is utilized by the tachycardia. Pacing isthmus at the cycle length 20 to 40 ms shorter than the tachycardia cycle length. No change on surface ECG. No change on intracardiac recordings. Tachycardia resumes its original cycle length upon termination of pacing. By pacing near the critical isthmus, entrainment pacing techniques can be used to verify that the isthmus is utilized, and therefore can be ablated. Concealed entrainment is observed when pacing at the critical isthmus. No changes should be observed in the flutter pattern on the surface ECG or the intracardiac recordings. The tachycardia will return to its original cycle length after termination of pacing. Entrainment pacing. Concealed entrainment, post-pacing interval equals flutter cycle length. 220, 220, 220, 220, 220, S, 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 250, 250, 250, 250. Treatment of atrial flutter. Treatment options: acute A flutter, pharmacologic therapy, rapid atrial pacing, direct current cardioversion. Two separate goals are used to treat atrial flutter. The first goal is to terminate the flutter and prevent a recurrence. The second goal is to control the ventricular response during the arrhythmia. Treatment options: acute A flutter, pharmacologic therapy for rhythm control, 4-ibutylide, oral flecainide, single dose of 300 mg, oral propafenone, single dose of 600 mg, pharmacologic therapy for rate control, 4 calcium channel blockers, verapamil, diltiazem, 4 beta blockers, esmolol. Two separate goals are used to treat atrial flutter. The first goal is to terminate the flutter and prevent a recurrence. The second goal is to control the ventricular response during the arrhythmia. Treatment options: acute A flutter, rapid atrial pacing. Method of choice in post-cardiac surgery atrial flutter. Pacing should be performed from high right atrium because the appearance of positive atrial complexes in ECG lead to is the hallmark of interruption of atrial flutter. Ramp pacing at a rate about 10 bpm faster than flutter rate and then gradually increased until the atrial complexes in lead 2 become positive. Burst pacing at a rate of 120% or 130% of the flutter rate and continued for 15 to 30 seconds until the atrial complexes in lead 2 become positive. If flutter continued, pacing rate should be increased by 5 to 10 bpm. Recommended minimum duration of pacing is 10 seconds and stimulus strength of at least 10 mA is needed. When esophageal pacing is used, a duration of at least 9 to 10 ms and up to 30 mA in strength is needed. Pacing should be initiated at a relatively slow rate to demonstrate that no ventricular capture is inadvertently produced. Treatment options: acute A flutter, direct current cardioversion. Contraindicated in patients after having recently eaten or those with COPD. Using a standard shock, at least 50 J is generally recommended. Because 100 J is virtually always successful and virtually never harmful, it should be considered as the initial shock. Treatment options: chronic A flutter, pharmacologic therapy. Currently Class IA, IC and 3 antiarrhythmic agents have demonstrated efficacy in suppression of atrial flutter. In the absence of structural heart disease, Class IC are the drugs of choice. Class 3 likewise may be effective. Catheter ablation therapy. Two separate goals are used to treat atrial flutter. The first goal is to terminate the flutter and prevent a recurrence. The second goal is to control the ventricular response during the arrhythmia. RF ablation of typical flutter. Catheter cuspidismus is a target for typical and reverse typical flutter ablation. The endpoint of ablation is bidirectional isthmus block persisting for 25 to 30 minutes. The precise point of the isthmus that the ablation line should cross is variable, however it is usually midway between the septal and the anterior RA, 6 o'clock of the TR and a 45 degrees low view. Oblique view of right atrium. Superior vena cava. Crista terminalis. Fossa ovalis. Pectinate. Muscle. A review of landmarks is helpful, before discussing ablation techniques. Eustachian. Ridge. Orifice of coronary sinus. Inferior vena cava. Nutter F. Atlas of Human Anatomy. 1989, Plate 208, RF ablation of typical flutter. A linear lesion needs to be created to sever the macro-ray entrance circuit. The lesion starts from the tricuspid annulus and runs back to the IVC. The lesion must be constant and contain no skips, otherwise the circuit can remain. Termination will occur during RF delivery. Bidirectional block is confirmed for acute success. Ablation of isthmus-dependent flutter, clockwise and counterclockwise, depends on complete, bidirectional block at the isthmus, catheter location for atrial flutter ablation. Crista. Free wall, atrial flutter ablation. AFL termination. This slide depicts termination of atrial flutter during RF current delivery. Conduction block. Before the ablation, pacing near the CS os would allow the impulse to travel in both directions, eventually colliding on the lateral wall. After ablation, pacing near the CS os only allows the impulse to travel in one direction, eventually terminating at the line of block. Singer, Interventional in Electrophysiology. Williams and Wilkins 1997, 367, Isthmus block, activation sequence during pacing. Proximal CS pacing. Low RE pacing. Assessing isthmus block during CS pacing. No block. No CTI block. CTI block. Other markers of conduction block. Increase in transisthmus conduction time. Differential pacing. Double potentials. 100 to 110 ms interval between potentials along entire ablation line. Reversal of electrogram polarity on the opposite side of the ablation line from the pacing site. Change in P-wave morphology pacing lateral to the ablation line. This slide summarizes potential markers of conduction block in the common flutter isthmus. First, an increase in transisthmus conduction time with differential pacing so that after block is achieved, pacing on one side results in a long conduction time to the opposite side. If you move the pacing site a little bit further from the line of block, you will see that the conduction time to the opposite side decreases when you have block. This increases when there is still slow conduction through the Flutter isthmus. Secondly, double potentials, as we discussed, with a relatively long interval of more than 100 to 110 milliseconds between the two potentials. We like to see this present along the entire ablation line. If we move our pacing site a little bit further from the line of block, then the conduction time from the pacing site to the potential generated by the wavefront activates the distal side of the line becomes shorter and that to the proximal side becomes a little bit longer, and the opposite occurs if there is still conduction through the isthmus. Thirdly, reversal of the electrogram polarity on the opposite side of the line of block, when block is achieved. And finally, one can also look for changes in P wave morphology when pacing in the low lateral right atrium on the free wall side of the line of block, and these are all reviewed nicely in the references listed at the bottom of this slide. On a daily basis, we find that interpreting the double potentials and simply doing differential pacing is quite useful. There are times where the double potentials are not easily detectable in the common isthmus, particularly if you have had to do a lot of RF and you have low amplitude signals everywhere through the isthmus. Then it is useful to have some of these other markers to help confirm when you have conduction block, isthmus block, differential pacing. Isthmus block, double potentials. Isthmus block, change in electrogram configuration beyond the line of ablation. Complicating factors in atrial flutter ablation. Fragmentation of isthmus electrograms after radiofrequency application. Fragmented continuous electrogram at the gap of the ablation line. Terminal crest permeability, mimicking isthmus conduction. Success rates of catheter ablation of atrial flutter. Acute follow-up long-term study ASH success, %, Mo, success, %. Feld 1283-467. Cosio 978 1878. Lesh 1894 9.667. Calkin 1681 1069. Kerkorian 2286 1377. Fisher 1890 2083. Steinberg 16 75. Petit 12 992. Saxon 5188 1482. Cockums 2095 875. Nakagawa 3110 83. Petit 4498 12.150. Fisher 295 2485. Complications of flutter ablation. Pain, especially if close to the septal RA. Pain is usually controlled by force sedation. Avenue block, especially if RFA applicated close to low portion of Koch triangle around the CS ostium. Avenue block may be related to vagal effect. Avenue block was completely reversible spontaneously or preventable by atropine. There are no report of tricuspid valve dysfunction or coronary artery obstruction. Clinical course and recurrences. Since adoption of isthmus block as an endpoint, recurrence rates less than 10% are commonly reported. Appearance of other types of flutter during follow-up is unusual. The main problem during follow-up is atrial fibrillation, usually paroxysmal form, in greater than or equal to 30% of patients. Summary. Atrial flutter ablation is an effective way for atrial flutter control with low risk of complications. Improved mapping techniques along with enhanced imaging will improve the success rate of flutter ablations. This module has discussed the various types of atrial flutter, along with treatment modalities. The use of RF ablation for atrial flutter is a new treatment option for selected patients with atrial flutter.